Welcome to Mind Shield. We protect the mind and pursue the truth. Let's get started.
When the emergency room doors open at night, they open into one of the most trusted spaces in modern society. A person arrives afraid, exhausted, overstimulated, and desperate for help. The lights are too bright. The questions come too fast. The forms are too small for the size of the experience. They are not asking for a theory. They are not asking for a debate. They are asking for a witness. This presentation is called Doctor Who Doesn't Get It, because the problem is not always malice. Sometimes the doctor does care. Sometimes the nurse is doing their best. Sometimes the institution is full of good people operating inside a system that has no category for what just walked through the door. The patient says, "I feel pressure. I hear something inside my head. I feel heat under the skin. It follows me. Something technological is happening." The system hears, "Psychiatric presentation." And in that instant, the case begins to collapse. Not because the facts have been investigated, but because the language sounds familiar enough to be filed away. This is where Mind Shield enters the conversation. Not to demand blind belief, to demand a disciplined investigation. The patient's reality begins in the body. Ringing inside the head, sudden pressure, heat under the skin, sharp localized pain, cognitive fog, balance issues, a strange sense that the body is being touched by something invisible. Then comes the most difficult report: voices, clicks, buzzing, or speech-like sounds perceived internally. This is where the room changes. Because once a patient says voices, people stop listening to the rest of the sentence. But the patient may also be reporting patterns: where it happens, when it happens, what direction it seems to come from, what devices were nearby, what changed in the environment, whether symptoms improve in certain spaces or worsen in others. That is data. Messy data, yes. Emotional data, yes, but still data. The patient may be terrified, but terror does not automatically erase observation. Fear can distort perception, but it can also sharpen it. Anyone who has been in combat, crisis, or threat conditions knows this. The body records details before the mind knows what to do with them. The right question is not, "Does this sound strange?" Of course, it sounds strange. The right question is, what can be documented, measured, compared, and ruled out? Because medicine fails when it treats unfamiliar language as proof of unreality. Now we move to the doctor. The emergency physician has a job that is brutal, fast, and unforgiving. They are trained to stabilize, prioritize, and rule out immediate threats. Stroke, seizure, head trauma, infection, intoxication, metabolic crisis, cardiac event, dangerous agitation, self-harm, harm to others. This training saves lives. But it also creates a funnel. Once the obvious emergencies are ruled out, the system looks for the next familiar lane. And if the patient is talking about voices, surveillance, persecution, or technology, the lane often becomes psychiatric evaluation. That may be appropriate in some cases, but it becomes dangerous when it happens before environmental, occupational, technological, and criminal possibilities are even considered. The blind spot is not that doctors are stupid. They are not. The blind spot is that emergency medicine was not built as a frontier forensic lab. It was built to stop bleeding, restore breathing, stabilize pressure, and move patients through a crisis. So when a new class of threat arrives, one involving electromagnetic exposure claims, cyberstalking, RF environments, sensor systems, surveillance, and possible directed energy, the ER has no protocol. And where there is no protocol, there is improvisation. And where there is improvisation, bias sneaks in wearing a lab coat. The dangerous shortcut begins with one word: labeling. Atypical presentation, fear, voices, belief of surveillance. The system sees a pattern it recognizes, so the patient is categorized quickly, often before the substance of the report is preserved. Immediate psychiatric categorization can lead to discharge without environmental investigation. The patient leaves with no measurements, no RF survey, no cybersecurity screening, no shielded observation, no forensic referral, and no record that the alleged source was ever examined. The patient remains in danger. The institution remains blind. But there is another path. Suspend assumptions, deploy environmental consultation, gather cross-disciplinary evidence, document the report with precision, preserve the patient's exact words, separate emergency risk from factual investigation. This does not mean believing every claim at face value. It means refusing to bury a case alive because it sounds inconvenient. A label is not an investigation. A diagnosis is not a crime scene report. And a frightened patient is not automatically an unreliable witness. The ghost in the machine hates paperwork, so we create paperwork. Dates, times, locations, symptoms, witnesses, measurements, changes in environment, changes in shielding, device anomalies, medical findings. The shortcut says, we already know what this is. The investigator says, prove it. This slide addresses one of the most controversial parts of the report, the idea that voices or sounds could be perceived without a normal external acoustic source. The microwave auditory effect, also known as the Frey effect, is a documented phenomenon in which pulsed microwave energy can produce perceived sounds such as clicks, buzzes, knocking, or in some research contexts, speech-like impressions. The basic concept is this: pulsed RF or microwave energy is absorbed by tissue. That absorption can cause extremely rapid, tiny temperature changes. Those changes can create pressure waves. The auditory system may then interpret those pressure waves as sound. That does not prove that every patient reporting internal sound is being targeted. But it destroys the lazy assumption that sound inside the head can only be internally generated. That distinction matters. Science is not supposed to be a locked door. It is supposed to be a flashlight. If a patient reports internal clicking, buzzing, pressure, or voice-like perception, the correct response is not mockery. It is structured inquiry. What did it sound like? Was it directional? Did others hear it? Did it occur near specific devices, rooms, vehicles, windows, rooftops, antennas, or workspaces? Did it change when moving locations? Did shielding alter it? The goal is not to jump to conclusions. The goal is to stop pretending there is only one possible conclusion. This slide asks one of the hardest clinical questions. How do we separate a typical psychiatric presentation from a suspected RF or directed energy exposure? The answer is not simple, but it is also not impossible. A typical internal psychiatric presentation may have a gradual onset, no clear spatial trigger, no consistent environmental pattern, and may persist across locations. A suspected technological or environmental exposure claim may involve sudden onset, location-specific symptoms, line-of-sight patterns, acute physical sensations, heat, vestibular disruption, pressure, tinnitus, or symptoms that change sharply when the environment changes. Again, none of this proves the claim. But it gives investigators a map. Medicine already understands differential diagnosis. This is no different in principle. You compare possibilities, you rule things in, you rule things out. You look for consistency, falsifiability, repeatability, and measurable changes. If symptoms persist everywhere, that is data. If symptoms stop in a shielded room, that is data. If symptoms spike near a specific location, that is data. If multiple witnesses observe the same timing, that is data. If devices show anomalies, that is data. This is where philosophy meets medicine. Reality does not care what category makes us comfortable. The job is not comfort. The job is truth. Here is the institutional failure in one sentence. You cannot diagnose an environmental or technological intrusion if you possess no tools to measure the environment or the technology. Most hospitals do not have a targeted EMF or RF exposure intake pathway. They do not have a protocol for radiofrequency environmental survey. They do not have a standing relationship with a radio engineer or spectrum analyst. They do not have shielded observation rooms. They do not have cyberstalking and device compromise forensic workflows attached to medical intake. So the patient enters a system that can scan blood, image bone, test urine, monitor heart rhythm, and detect infection, but cannot evaluate the invisible signal environment that the patient is naming as the source. That gap becomes a verdict. The absence of measurement is mistaken for the absence of cause. This is bad science. If a hospital does not test for something, it should document no environmental RF evaluation was performed because no protocol exists. That sentence matters. It tells the truth. It preserves the gap. And it creates the legal and ethical pressure needed to build the missing protocol. A better intake does not require the doctor to become an RF engineer. It requires better questions. First, spatial and temporal questions. When did it start? Does it change by room, vehicle, floor level, workplace, route, time of day, or proximity to specific structures? Second, physiological questions. Is there heat, pressure, vibration, tinnitus, skin pain, vestibular disturbance, balance problems, headache, cognitive disruption, sleep disturbance? Third, environmental questions. Have there been changes in nearby devices, smart meters, routers, antennas, vehicles, workplace equipment, neighbors, construction, or unusual exposures? Fourth, security context. Is there documented stalking, harassment, hacking, workplace conflict, domestic threat, legal dispute, identity theft, doxing, surveillance concern, or targeted intimidation? Fifth, evidence. What logs already exist? Notes, videos, witness statements, medical visits, device screenshots, RF meter readings, police reports, cybersecurity reports? This kind of questioning does something powerful. It calms the room. It tells the patient, I am not here to mock you. I am here to separate signal from noise. That alone can change the trajectory of the encounter. There are 4 things the doctor should not do. Do not ridicule, mock, or dismiss the patient's lived experience. Ridicule is not medicine. It is institutional laziness with a stethoscope. Do not argue metaphysics at the triage desk. The ER is not the place to debate the nature of reality. The ER is where you stabilize, document, and refer. Do not treat the patient's extreme fear as empirical proof that the report is false. Fear proves distress. It does not prove causation. Finally, do not collapse a complex case into a convenient psychiatric label before systematically ruling out environmental, technological, occupational, and criminal possibilities. This is the difference between skepticism and dismissal. Skepticism asks for evidence. Dismissal refuses to collect it. A good doctor does not need to believe the entire story immediately, but a good doctor should understand that the patient may be describing a pattern the institution is not yet trained to see. History is full of patients who were dismissed before science caught up. The future will be no kinder to our arrogance. Now we come to the Faraday cage question. Should hospitals create RF-reduced or shielded evaluation spaces? Not as magic. Not as theater. As controlled diagnostic baselines. A Faraday cage or RF-shielded room can help reduce certain external electromagnetic signals. If a patient reports symptoms that appear linked to external RF exposure, a shielded environment creates a comparison point. If symptoms decrease inside shielding, that becomes a clinically relevant data point. If symptoms persist inside shielding, that is also clinically relevant. Either way, the hospital learns something. This is the heart of scientific investigation. Change the condition, observe the result. The shielded room does not need to prove everything. It only needs to create contrast. Hospitals already use controlled environments for many things: isolation rooms, imaging suites, sterile fields, sleep labs, EEG rooms, radiation-controlled zones. So the question is not absurd. The question is overdue. If modern life is saturated with signal infrastructure, then modern medicine needs at least a basic capacity to evaluate whether signal environments are relevant to patient complaints. The future is wireless. The hospital cannot remain blindfolded in a storm of invisible architecture. The patient belongs at the center of the investigation. Not the theory. Not the label. The patient. Around that patient, MindShield proposes a full-spectrum investigation model. The ER physician handles immediate stabilization and baseline triage. Neurology and ENT evaluate tinnitus, vestibular dysfunction, headaches, balance problems, auditory symptoms, and cognitive changes. A radiation safety officer reviews exposure procedures and institutional safety standards. An RF engineer or spectrum analyst evaluates environmental measurements and signal detection possibilities. A cybersecurity professional examines device compromise, location tracking, account intrusion, spyware concerns, and cyberstalking patterns. Hospital security and a patient advocate preserve immediate safety, dignity, and documentation. This is not overcomplication. This is how serious systems handle complex threats. Aviation does not investigate crashes with one profession. Cyber incidents are not solved by one technician. Battlefield injuries are not understood by one sensor. Complex harm requires a multidisciplinary response. Medicine alone cannot solve a technological abuse claim. But medicine can become the doorway to the right team. The MindShield protocol begins with recognition. Recognize reported targeted EMF or RF exposure immediately, without mockery. That does not mean validation of every detail. It means validation of the need for disciplined intake. Next, separate emergency medical risk from ongoing evidentiary investigation. A patient can need immediate medical stabilization and still deserve a forensic pathway. Then document the exact language used by the patient and build a precise exposure timeline. Exact words matter, timing matters, locations matter. Then preserve medical and technical records meticulously. Finally, refer the case into a cross-disciplinary network: medicine, engineering, legal support, cybersecurity, occupational safety, and patient advocacy. The core objective is simple: teach the difference between reflexive dismissal and disciplined scientific investigation. The doctor who does not get it may not be cruel. They may simply be untrained. So train them. Build the protocol. Give them questions. Give them referral options. Give them language that protects the patient and protects the institution. Because right now, too many professionals are improvising in the dark. This slide is the moral center of the presentation. Medicine should not become a courtroom that convicts the patient before evidence is gathered. That line matters. A patient in distress enters the hospital already vulnerable. If the institution responds with disbelief, mockery, or premature labeling, the patient is harmed twice. First, by whatever brought them in. Then by the system that was supposed to help. A doctor does not need to believe every bizarre claim immediately. But a doctor does possess an ethical duty to investigate what can be measured, documented, compared, and referred. That is the middle path. Not blind belief. Not blind dismissal. Disciplined humility. The physician should be able to say, I do not know what is causing this yet, but I will document what you report. I will evaluate immediate medical risks. I will consider environmental and technological possibilities where appropriate. And I will refer you to professionals who can investigate what this hospital cannot. That sentence could save lives. Because dignity is not a luxury in medicine. It is part of treatment. MindShield's call to action is practical. First, pilot programs. Implement RF-aware training modules in emergency rooms, urgent care centers, veteran clinics, and community health systems. Veterans matter here. Security professionals matter. People with histories of surveillance, conflict, classified work, cyberstalking, domestic abuse, or organized harassment may describe threat patterns that sound extreme but deserve structured documentation. Second, new protocols. Build standardized intake forms for reported directed energy, acoustic, EMF, and RF exposure. Include symptom timelines, environmental triggers, device anomalies, witness logs, and prior reports. Third, strategic partnerships. Create permanent investigative alliances between healthcare providers, RF engineers, law enforcement, cybersecurity professionals, safety officers, attorneys, and patient rights groups. This is how institutions evolve. Not through panic. Through structure. Not through belief wars. Through protocols. The future of healthcare cannot be trapped inside 20th century assumptions, while 21st century technologies reshape the threat surface. If medicine does not adapt, patients will keep falling into the gap. And the gap will keep getting wider. When technology evolves faster than training, patients fall into the gap. That is the final message. MindShield exists to close that gap. One protocol. One witness. One documented case at a time. The goal is not to make every doctor an expert in directed energy, RF engineering, cyber forensics, or cognitive warfare. The goal is to make sure no patient is thrown away because their suffering arrives in unfamiliar language. The future will bring stranger cases, not simpler ones. More sensors, more signals, more wireless infrastructure, more AI-enabled surveillance, more invisible systems capable of touching daily life in ways most institutions are not prepared to understand. So the question is not whether hospitals can afford to investigate. The question is whether they can afford not to. Every report should become a record. Every record should become a pattern. Every pattern should become a protocol. And every protocol should move us closer to truth. Final evidence note. Document dates, times, locations, symptoms, witnesses, device anomalies, medical visits, lawful recordings, environmental measurements, police reports, cybersecurity findings, and any changes observed in shielded or controlled spaces. Pain without proof stays trapped in the body. Documentation gives it a path into the world. That is where the case begins.